Good morning, everybody, and welcome to our closing session. I'm Ana Diez, Roux. I'm the Director of Urban Health Collaborative, and I have the pleasure of helping to moderate this last closing session, which we thought was really important to have as a space for reflection, comments, synthesis, kind of tying together many of the things that we've been talking about over the last couple of days. And you know, when we started planning the symposium, we were also thinking about the past 10 years and the next 10 years. And so one of the things we want to do is push us to think a little bit about what are some of the big priorities and challenges, but also challenges in a positive way. Challenges meaning things that we need to deal with, but that create huge opportunity for improvements. What are some of the challenges for the next 10 years? And 10 years is a long period of time, especially today with everything that's happening and all the uncertainty. But we're going to kind of let our panel, help us think about that. So we're going to start out with a few very general questions for each of the panelists, and then leave plenty of time to open it up to you for your thoughts, any reflections, any messages you want to share with this group of people committed to really improving health in cities all over the world and achieving health equity. So we have four panelists today. One is Michelle, who of course you heard give a fantastic lecture this morning, Michelle Morse. For some of you, just in case you missed the talk, she is acting health commissioner and chief medical officer for the New York City Department of Health and Mental Hygiene. She's a physician with extensive experience in public health, health equity, and anti-racism work and its implementation in a health department context, and general activism in favor of urban health and health equity. We also have Usama Bilal, who is a co-director. I'm fortunate that he is the co-director of the Urban Health Collaborative, and he is associate professor of epidemiology and also a physician originally from Spain, whose work focuses on health equity, place and health, and many other issues. We also have Waleska Caiaffa, who is a pediatrician originally and a professor of epidemiology and public health at the School of Medicine at the Federal University of Minas Gerais and Belo Horizonte in Brazil. She is a lead in the Sauerwald study for Brazil, and Waleska and I met as MPH students. I will not say when, it's a long time ago. Just a few years ago, right, Waleska?
Oh yeah. My goodness. Wow.
So, and last but not least, Jamile Tellez Lieberman, who is a senior vice president of community engagement, research, and health equity at Esperanza, which is a multi-service organization serving North Philadelphia, where she directs community-engaged research and equity-focused initiatives to improve Latino health outcomes. And Jamile is a graduate of our school, both MPH and DrPH, I'm very proud to say, and so we're delighted to have her with us today. So to get us started, I'll start with Michelle. Of course, we heard such a great talk from you this morning. A few things that really struck me is we need to get creative. Mm-hmm. I really like that, and that it's a mistake to shrink our ambitions for systemic change now. Mm-hmm. And if you'd like to reflect on, from where you are today as acting New York City Health Commissioner, what do you see as the biggest health challenges for urban health leaders like you over the next, if I can say, 10 years, or however long you feel commenting on? What do you see as the biggest challenges and opportunities for us?
Not a small question. Yeah. But happy to kind of start with a few reflections on that. And I mean, there is so much to say. I love thinking about the 10-year horizon. It like helps me to get out of the like kind of day-to-day survival mode that I will admit I am kind of in right now, and remind myself, ourselves, that there is this long arc, right? And that even though it may feel like the situation we're in right now is kind of a unique, I don't know, stew of complications, political, public health, and otherwise. Versions of this have happened over history. Versions, lanes, kind of samples of what we're seeing right now have happened before. And so, yeah, just remembering to stick in it for the long haul is so important, and I feel like public health people are naturals at that anyway. But some of the things that come to mind for me, just again thinking about kind of the long arc, I think one of the big opportunities is to kind of update and redefine public health in the 21st century, right? It is, I mean, most people agree, I think, right, that the 20th century was in many ways defined by the life expectancy gains that the field of public health brought to the world in so many ways, and not fairly or equitably, but brought into many places. And so if it was, water sanitation and vaccination and, a few other kind of major leaps forward in the 20th century, what is the 21st century version of those? How do we define that? What does success look like? For me, a big part of it is making sure that the equity strategies that public health has sometimes used, but not always, are central to whatever that 21st century redefining, reimagining of public health looks like, and it's not ensuring that that's not the side hustle or kind of extracurricular, but actually central to it, as in like we cannot be successful in 21st century public health without leading with health equity strategies. I think that's one piece. And then the other thing that I'll say is I do think, and this is a space that I haven't spent enough time in, but the challenges and opportunities in climate work is like, it's so public health. I think like I don't see a 21st century public health without climate also at the center. And then finally, what is keeping me up at night is like the threat of war. And I've been wondering like, well, what is the status of the global anti-war peace movement, or at least the US like anti-war peace movement? We're gonna need to dial up that organizing a lot, I think. I think it is one of the big threats of the 21st century. And public health has sometimes stood on the side of anti-war efforts, but not always. And that's a part of our history that I think we have, as a discipline, have to really critique, dig into, and challenge ourselves to redefine in the 21st century as well.
Thank you. Redefining public health, equity, climate, and war. Really great points for us to think more about in urban health and focus on. Usama, as a researcher, there are many types of research, right? When people use the word research, they might be meaning different things, right? And so thinking broadly about research and what research can bring to action, what do you see as a researcher? How can we as researchers best support improvement in health, urban health and health equity from your perspective over the next 10 years?
Easy question, yeah?
Easy questions, they're all easy questions.
Yeah, so I think one of the things I will say to start with is just staying within research, public health research, the research we do, is broadening the scope of what we do, the imagination, like, with sociology, there is that concept of the sociological imagination that challenges us to, think broader, think upstream, which I think a lot of people here are doing, as we have seen. But I think we need to keep going upstream. And I think that even though there is a very immediate need to certain interventions in certain places, I think the big drivers of health are even higher up. And are even higher up in inequality, structural inequality, and structural racism, and all of the other forms of inequality that are out there. But it also challenges us to think about the, capitalism itself and the way that it shapes inequality. So I think going even more upstream is a way of getting there. The other thing I will say is that, well, you asked me about research. I think training is a very important part of it, and especially training researchers, in my case. That's one of the main things I do, I think, as part of my job. And the way we do that, I think, is we need to continue thinking of better ways to instill that idea of, imagination, encouraging people to be brave in the kind of research that they are doing. Because at the end of the day, the incentives are for us to not be brave and to do the things that are easy. Not easy maybe, but at least that are predictable. And I think going even more upstream gives you more unpredictability, which makes it harder to finish your dissertation for those of you that are in doctoral programs. So it's a delicate balance there. And then the last one is, I always say that the entire goal of my research is to try to at least a little bit shift some public narratives, because I think that's where we win the battle for public health, with the public, not with, in my view, not with policymakers, not with anything else, with the public, which ideally are the people that choose policymakers, not the other way around. So I think that narrative fight is very important, and that's fought in many places. And one place where I think it's fought, it isn't directly connected to the public, but it's connected to research, is the editorial process. And I've in the last few months, I've done a lot of work in the editorial process in journals. And there it's a place where actually most people in this room are involved in that, as either reviewers or editors or authors, etc. And I think that's a place where that is fought, like what is accepted in journals, what the big journals publish, that access to that, access to science in general is another big fight that I think we keep on having. That's less connected to the public, but it is connected to training and the research that is privileged and funded afterwards. So those are my main three, I think.
Thank you. Yeah, so research is a way to change the paradigm, not just as a way to understand etiology in the narrow sense or evaluate policies, but as a way to just change the narrative, the public perception of
what produces health.
What produces health, and therefore what we need to do to move it in the other direction. Imagination, brave research, and how to think about training perhaps in a different way to help achieve these goals. Great ideas. I love these visionary ideas. Jamile, you from where you sit on the ground, keep us real here. What from your perspective, what do we need to be providing from academia, from public health leadership and as practitioners? What do you see as the most important things that we can deliver, that we should deliver to communities to improve urban health?
Right. That's also not a simple question. There are layers, right? Nuances. And yes, I am sitting from a perspective of being in the community, serving North Philadelphia, Hunting Park, Feltonville, and Juniata neighborhoods, and being very much in the trenches on the day-to-day. So it's like different hats, right? This idea of research and then serving the community and making sure to address those needs. What I've seen, I think, in my time at Esperanza and with my training from Drexel as a researcher and then needing to serve and act at Esperanza is there's sometimes like a disconnect between what's going on with research, like over here and up here, right? And then there's the community kind of living it down over here. And there's not a lot of that connection between the two. And I think the community has, they're the experts of their lived experiences every day. We may study it, but they're very much the experts. And I think they're like suspicious a little bit of research and what does it mean, what's going to happen with their information. And unfortunately, I think that's as a result of sort of like a cycle of researchers coming in to do research, then they take the data, and then a paper's published like a year later that the community doesn't read, right? And then the community doesn't really see that benefit. And they're like, hey, what happened? And I told my story to someone, what's going to happen? Is something going to come out of it? So I think that when we're thinking about research, we should always think about what is the product of the research? What is the benefit to the community? Because a lot of what I do is sit and think about I understand the long-term investment in scientific knowledge and understanding and evaluation and contributing to, science and everything like that. But I also need to think about the community needs things now. And so I have to, judging a little bit, sort of walk that line between that space of, we would love to do this research to understand this particular phenomena or that, but we need to figure out a way to deliver it back to the community in the short term, and there's some sort of immediate benefit aside from incentives for the research itself, right? So that they can sort of see that research leads to something.
Yeah.
It is not its own thing that we're just kind of doing, because that's where I see a little bit of the risk now, is like there's more mistrust in research, there's more mistrust in science, and there's a lot of things we could be doing about that, but I think one of the important things is think about the approaches through which we do research with and within, alongside communities as opposed to on them, and then figuring out what kind of can I do in doing this research, what can I give back immediately that is, relevant and resonates with the community so that they feel like it was a valuable experience to participate in the research, right? So I think that's something I've learned.
Thank you. That's very important, being much more deliberate in our efforts to return, communicate back and focus on topics that are relevant, but also report back, right? What happened? What do we find? What does it mean, right? So I think that's really, really important. Thank you. And Waleska, last but not least, from the global health, I know you can't speak about all global health, but from the global health, from where you sit in Brazil, I mean, you led Waleska led Urban Health Observatory, one of the first urban health observatories, actually, we looked at when we were thinking about Urban Health Collaborative. We looked at Waleska's Urban Health Observatory in Belo Horizonte. From where you sit in Belo Horizonte and your experience in Latin America in general, what do you see as some of the opportunities in the lower and middle income countries, or some of the experiences that you've had in terms of things that have worked or things that have not worked as well in improving urban health?
Thank you, Ana. Well, thank you very much for letting us know from the observatory that you look at our experience before.
Yes, absolutely.
But I'm going back to the history. We look at the London Observatory when we created ours. So which doesn't exist anymore. So, but anyway, I hope this doesn't happen to us. But anyway. I made my notes, but I think I'm going to throw them out in a second. I was thinking after my colleagues that I'm collecting T's. I'm collecting time, trust, transparency, training, and tired. I think that time is very important. We founded the observatory 22 years ago, to be very precise. And as I mentioned, we looked at other experiences as well all over the world. And in 22, we start looking at some events, health events, because now we are discussing about multi-exposure, which I think that this is something that we shift from, especially now in the climate change era, I'd say. So looking at that, we've learned that it takes too long to organize, and from the academic point of view, to make this, to bridge this gap between stakeholders, policymakers. And believe it or not, we've been doing that over, I don't know how many different mayors. And this time is very important. Time is very important when you want to do something that now we are doing, that's, excuse me, looking at some ultra-level data or ultra-local data, trying to combine multi-methods. We've seen here a lot of experience And I think that the combination of those experiences, it's a little bit hard, but we have to do that. We ought to do that, because otherwise time will devour us. And time, I can tell you, when we start one project, it's called BH Viva. We evaluate one project, housing, and a very comprehensive urban transformation in Belo Horizonte. And just to have an idea, we've been collecting data up to now. We use mortality, morbidity data. But our first, we start in 2012, but we look back at data from 2002. But the first publication, it was in 2015, when we evaluate the homicides. And that was a very preliminary results. And we were able at that time to go to the stakeholders, to the policymakers, and show them that it was very interesting, because they had the impression that the homicide would decrease, but they never had that measurement. So now, 2024, we were able just, keeping going, keep collecting data, keeping struggling, because, to get data, it's a big effort, very big, to convince people that they have to detach with their data, because it's important, of course, under all the ethics procedures, but it's hard. And to get the data, geocode the data, organize the data, harmonize data, we know that because, as a Salubal team, we've been struggling since 2017, right? Yeah, I guess so. Anyway, so now we were able to show in a very sophisticated analysis using a difference in difference that when the intervention, when there was some vulnerable areas, because I forgot to say that it's really vulnerable in the favelas, in slums. So when the intervention took place a long time ago, so now we can confirm, it's not a causal, of course, but we can confirm that the homicide rates are going down when we compare cases or slums with intervention without intervention. And only now, and we still haven't published that. Sorry, Anna. And I have to say that, yeah, Usama, Journal of Urban Health, perhaps. But I just have to say that it takes too long.
Yeah.
Takes too long to train, because I think Usama raised something very important. It's the capacity building. It's quite important, and we need to rely on these new generations, which for us is a regeneration. Oh gosh. Anyway, but just because this new generation, they have strong and view, and they are very well prepared to struggle with all those difficulties that we've been on the field for such a long year. And I'm not going to do all those T's, because otherwise trust and transparency. I think this does a lot with the community and also for the stakeholders, because sometimes we did some qualitative study in the same study, and we saw that, some people, they didn't like the intervention. And now, in 2 weeks, we are going to, do another meeting. We will have another meeting with the policymakers, and we were struggling. Shall we show it? Shall we don't show? No, we have to show them. This is very important because, through the qualitative and several other approaches, we found that, some residents are not happy with the intervention. So we have to be very transparent. And finally, the training where I said that, and tired. Yeah, sometimes we get very tired.
Tired. Okay.
But yeah, well, it's tiresome. But anyway, it's so revigorate when we've been here and we see so many young people that even were not born at the year 2000, for instance. But we are young too, don't worry. But so I think that, yeah, it's revigorate. And last but not the least, I just want to remember in 2015, I'm very sentimental, no? In 2015, when the first symposium was in place, I remember the title, and it was, do you remember, Anna?
Reimagining Health in Cities.
And 2 dots, generate new ideas. So I think that 10 years after, we are here trying and, generating a lot of new ideas. So I think this is very invigorating. Thank you.
Any reactions, anything else anyone from the panel wants to add based on what you've heard? Or,
I did want to comment on what you said, Michelle, about climate. I think when I was here at Drexel, I didn't necessarily dig too deeply into climate and environmental justice. I was focused on, where the research was leading me and the dissertation, everything like that. But then going just up to North Philadelphia, I've had to very quickly learn a lot about environmental justice, climate resilience. Our community is plagued by high heat, and it's getting worse every summer. And it's just front of mind right now is climate change and climate resilience. And we're doing a study right now trying to understand, to define what climate resilience means for our community, to make a plan for implementation, eventually for implementation, so that we can better protect our community as the, climate change still to happen. So I just love that you said that, because I don't know if it was always there in the conversation of public health when I was being trained here, but now I'm it's right in front of my face and I need to learn a lot about it. And it's probably one of the things that is most front and center of our community's experience. And unfortunately, the way, I've seen climate change and climate resilience kind of play out in the neighborhood, from the neighborhood perspective, is it puts our community in sort of a corner where they can't make a better choice. It's like they only have bad choices. An example of this is, we have high heat days and the city does great warnings to say, this is a high heat day, these are the services, the cooling centers, things like that. These are the things we recommend that you do, stay indoors, stay, with shade and cooling and things like that. But at the same time, there was the fires in Canada and the smoke came, so there was also the air quality warning. So then our community was like, well, if we're supposed to close the windows to keep the bad air out, but it's also, we're so hot and we need the windows open, then what do we do? How do we deal with that? So I think it brings home this idea of, intersectional vulnerabilities and trying to figure out, understand that, of course, and their experiences, and then figure out how to react to that. How do we do things short term, immediate reaction, to reduce, morbidity and things like that and mortality, but then longer term, what do we do, right? Esperanza is doing a lot of tree planting. We're investing in greening to hopefully lower temperatures long term for our community, but that's gonna be years and years before those trees reach maturity, if they do, right? Because then the other challenge is to keep them alive once you plant them. So then I also need to think short term, what can I do? Each summer is getting hotter and hotter. So that just really struck home, and I was so glad to hear you say that, because it's I was not anticipating it, but now it's here, and that's definitely a focal point for Esperanza and the communities that we serve right now.
I mean, in many ways, the climate crisis, like the pandemic, right, is kind of shining a spotlight and making visible all these structural issues, which are the real fundamental drivers, right?
Yeah.
History and other, the way we're organized socially, basically.
Right.
So I think in some ways we have to address the climate crisis, but also address the underlying issues at the same time.
And I don't think climate experts and climate scientists are thinking about the health aspects. You really don't see that layer there. It's like, again, the public health and health and things like that, and then climate.
Yeah,
So like, they're not making that connection, so I think we need to do that for them and bring them to be part of this table, to have these kinds of nuanced conversations, because it's not happening naturally, right? I don't think they're really even thinking about that too much, so. Agree.
Any other thoughts? If not, yes, go ahead.
Yeah, one thing I wanted to mention is, I think, battle here of timescales, because there is a lot of need for things now, right? Evidence on things now, but then the research process, as Waleska mentions, takes a lot of time. And some of the outcomes we want to look at, as we saw in the prior session, take a long time to develop. You do an intervention today, what effects it's going to have on poverty when you are 25? It's going to take 25 years. So I think that constant fight between timescales and then the academic timescale. I was talking about journals before, the publishing time. I remember with COVID, shone a light into many things. I remember doing the first analysis of COVID inequalities in incidence and mortality in New York, in Philly, in other cities, in March of 2020, and the first paper came out in April of 2021.
Right.
Because we went through a long review process. I remember that paper. It kept going on. Review number 4, review number 5. But you want to do it well, so that the results are then something that people can trust, and they are not retracted later, causing a lot of other issues. So it's how do you find a middle spot there that make the evidence useful yet trustable?
Yeah. I mean, at the same time, we know a lot, right? We already know a lot. So how can we, the evidence that we already have, the knowledge that we already have, some of which is published, some of which is not, just fine. In some ways, the publishing process is like a world of its own. But how do we, what can we do to facilitate using what we know, transform it into action? I mean, this is a challenge, of course, health departments, this is what you live day in, day out, right? But I don't know, this is an open question for anyone, but are there things that we can do as an urban health community to help push forward what we know into action? I know this is a complicated question, but are there things we should be doing completely differently than the way we're thinking about them now? I mean, who should we be talking to most? Is it policymakers? Is it the public who are electing the politicians who are in government? I don't know. I don't know if anyone has any thoughts on that. Are there things we should be doing differently to help translate what we know into real action more quickly? Is that possible? I don't know.
I'll just share a brief reflection, because the climate stuff is also top of mind for us in New York City all the time. And about a year and some change ago was the first time the fires in Canada started impacting air quality in a very noticeable way. And I'll never forget, because we were completely unprepared in the New York City Health Department. There had not been an incident like that, where literally suddenly within a few hours the sky was gray, people were coughing, emergency room visits skyrocketed. And initially it wasn't even clear, like, well, what's happening here, right? And then of course it became very clear very quickly that it was the fires in Canada, and that was causing the air quality. So we had to create a whole new protocol. And we created a new health action alert that we send out anytime the air quality is predicted to be a certain level of bad. All the providers in the whole city now get that in advance. And theoretically, what they could do is talk to their patients, send out a message to their patients, especially those with chronic disease, chronic lung disease, et cetera, to kind of, give the advice. But if the advice is not implementable because of all of the things that come along with living in poverty, living in a neighborhood where you have no trees, et cetera, it doesn't go anywhere. But I will just say, for us, we were very clear that we were unprepared, essentially, for what was coming. And then the other thing I will say is we've been using the heat vulnerability index methodology to distribute a number of different, like, free, cool, kind of, heat heat issue, kind of heat addressing interventions, whether it's free air conditioners, solar panels, and a number of other kind of interventions. But then there was a challenge by a group of lawyers to us saying, you should not use the heat vulnerability index because Black race is one of the variables, and that's unfair.
Ooh.
And we were shocked because, of course, like this is a very well used evidence-based tool that allowed us to focus resources according to need, and then to get caught up in all of these legal battles just again is like a reality of the context in which we're all trying to practice public health right now. That's very challenging, but we'd love to share like a community of practice around that.
Yeah.
Would be so interesting, right? Because we know we're unprepared, and like, how are we getting prepared? Honestly, I'm not sure. Yeah.
I think, Anna, I think we have to be everywhere. This is, tiresome again. But, you have to be in an academic field, of course, but you always have to be very close, if not you or your team, some person that it is very key in the institution that, trying to communicate and involve all the actors that are involved in urban health, because, it's a systemic thing. But if you have one person, one key person, let's say, in one sector at the city hall, for instance, and you can talk to this person or to this team, it's really good. I mean, if you keep doing that in terms of over time, you increase your communication in terms of policymakers. Yeah. And the same happened with the community, the community leaders, social movements. You have to have some key persons that you, it's engaging with you in this process of communication. And of course, we discuss a lot about the media, The media is very important, especially now for the climate change era. Oh, the media is so important because sometimes we get the information through the media, not through anything else. So I think it's very important.
Okay, I'd like to open it up. Questions, comments, reflections. Yes, we have one there. Other ideas about what we should be doing the next 10 years?
I work for the health department here in Philly, and I heard you talk a lot about upstream. We should be focusing on upstream, what we're doing upstream, about climate change. And I guess I'm just wondering, on a practical level, what should be the role of local health departments in addressing issues that have typically fallen to the realm of other agencies, right? I work a lot with motor vehicle crashes. We're currently doing an evaluation on home improvements to rental properties, right? But we don't necessarily have the jurisdiction or the authority or the budget to implement these sort of large-scale upstream infrastructure changes, even if there's the will and even if other agencies want to collaborate with us. So I guess I'm just wondering if you have any tips or how or to what extent we should be involved in that versus just sort of like trying to infuse a public health perspective in these other agencies.
Do you want to?
Is that for you or for the front? Yeah.
Whoever wants to take a stab.
Well, I can share an initial reflection, which is, I think ideally local health departments are the people like throwing the data in the face of other agencies, trying to compel them to act. But if you don't have a city leader where that kind of collaboration is encouraged, it ends up with being, I would say, bless you, a lot of work and no change. It is one of the hardest things I think city government does, is trying to collaborate across agencies. And public health is so inherently multidisciplinary. We have to be the best people at doing it, I in my opinion. Now, do we always rise to that occasion? Not necessarily, but I will say at least the way city government's structured in New York City, we have a deputy mayor of health and human services. And so I end up spending actually a lot of time with a lot of, commissioners from sister agencies whose portfolios are quite relevant to mine. Our public hospital system, our social service system, et cetera. But Yeah, I mean, there's no easy way to do it from what I've seen. The only thing I will say is I've seen external advocates and activists be really effective in that. And I will say, like the New York City Health Department, one of our many secrets, we have a massive secret network of, organizers and activists and organizations that we engage with who, we show some data and they do things with it. So I think that helps because we really, you can't do it all.
Yeah, I was gonna say, the way that Esperanza has been working with the Department of Public Health here in the city is we're, building a relationship with, a couple key folks, and these are the folks that we really trust. And then we figure out together what we're gonna do on the ground. And they could feed us data. They could also just provide some infrastructure, some resources. And then we can go out and do that because we're a little bit more flexible. We're able to pivot. We're able to also be an in-between between other city reps, like council people, right? And do advocacy that way. So I feel like, if you're feeling frustrated, right, Leah? If you're feeling frustrated, sitting in the part wondering, I know I have all this insight, right? But it's not, I don't know how to help to translate it. I think there are, community activists, organizations who are looking for a little bit of that insight to help just guide them a little bit. And they have some of the energy and some resources to go and figure something out. And they're also not necessarily afraid to try and fail a little bit, right? Because that happens, right? But they're like, cool, yeah, we'll just try that, we'll try this, we might fail, but then we'll, figure out, build a momentum, figure out what does work over time, and keep going, right? So it's it doesn't have to be led by the city, and I know sometimes the city is maybe not necessarily wanting to be lead and be visible, because then it looks like maybe you're investing in certain neighborhoods over other neighborhoods, right? There's all of that, right? But you can be sort of in the back end, and that's sort of what we have figured out is we have our champions, our allies at the city across the different sectors. They're the folks that we call and the folks that call us. And then we figure out what can we do together. And they've been very happy to just sort of let us take the lead, which I think is the key piece here, right? And try not to drive the train a little bit, but or drive the train too much. But, just sort of shoring up community capacity to sort of try out some things and react to what the insight is. So I think there's a hunger for that, right? And then that would be a great way to sort of figure out how to translate things more quickly outside of the city structure, right?
Yeah, and from the point of view of the academic view, it's very interesting because we've been in a project in the last 2 years that is called Change Story with the PI is Helen Pineo. And that project, we had as a scholarship, with a scholarship, the same scholarship that the doctoral student has, one community representative of social movements. And this has been very interesting because this is working like a snowballing thing in terms of to get to know, because you are in silos, no? To get to know what's going on in the community all over the city. The thematic the problem that we are looking there is the food insecurity. And we've been discovered so many initiatives that it's really, really interesting because we didn't know anything about that, about social movements. I have no experience on that. But now we know lots of different, and they are very eager to get information, data, and some, feedback. So I think this is very interesting. This is a Robert Wood Foundation grant, and I think this is a very interesting way to, to break this barrier.
I just wanted to add that another thing will be having academic partners as trusted third partners who help with evaluation things or consultation things. The other thing is that sometimes, although health departments are great generators and users of data and analyzing, etc., sometimes it also helps having an external person show the data in ways that may help with some things. And I'm thinking plugging for the UHC City Council dashboard. I see Tamara over there, and your others are in the audience. That allows you to see health and other indicators by City Council in Philly. and allows people to advocate for certain things with their city council members specifically, there are certain actions that council members can take, for good or for bad. But, that can be also something that can be useful. But that requires collaboration, and that goes into something that I think with City Health Commissioners yesterday, data use agreements, data sharing is so complicated within the city, with other people. That's very, very complicated.
But really thinking about, I mean, there are different ways, we could think of different kinds of partnerships between academic institutions and government, really, in ways that academia supports government, and not just for a specific project, this grant, it's about day in, day out, right? And so I think we have to think creatively about different models, and experimenting with different models and figuring out how to finance it, yeah, of course, but, we don't have to wait for things to be published. They don't all have to be studies. They can be just descriptive data that is powerful. And, and I think the whole issue of community and the public as actors too, not just government in urban health is really important, social movements. I think I saw some hands. Yeah, go ahead, Tina.
Thanks so much for this panel and for the whole experience of the symposium. It's been really wonderful. I want to ask about criticism. And it feels like we're in an era where a part of who we always have been in public health is that we have a tradition of being critical of each other and our students and ourselves. It's part of our training, it's part of our publication and grant systems. And when we have new evidence coming out, whether that's about a new protocol, a new tree planting, housing intervention in a vulnerable community, we look for alternate explanations for conflicts of interest. Like, we have this approach that looks to see if we can poke holes in what public health professionals are trying to do. In this time, it feels like there's a real risk that we're navigating where if we don't have open dialogue, then we get criticized for not having a diversity of viewpoints. If we reinforce kind of dialogue that calls into question what's really a consensus, like with climate, then that seems to validate viewpoints that are not helpful to advancing the health of the public. How do we create space for our students, for ourselves, to continue to have that constructive criticism and dialogue, and address the threat that it gets used against us in some fashion? That communities that are already questioning their trust, latch on to some of that criticism that others in the government or in outside organizations that would like to see public health taken down a notch latch on to, there's this criticism anyway, so they use that as a basis to dismiss the validity of what we're doing.
Any reactions?
Oh, it's tricky. So I'll say that I think from my point of view and the point of view of, in my case, academic research, this is going to sound very boring, but commitment to the scientific method, something that helps a lot, because in theory, you have good data collection practices, good analysis plans, you document everything. Theory, someone else could do that same thing. Now, that's a little bit naive, because it assumes that all of us will do the same thing in the same way. And I think something we need to acknowledge is that there is a lot of inherent bias that goes into any analysis because of different political orientations, ways of seeing the world, et cetera. And that's a fight in my head that's constantly happening. The fight between, this is a transparent thing that we are doing an analysis, very simple, it shows this, but then what are people going to do with this if this ends up there? And I think yesterday in the methods panel, there was a little bit of discussion about this. And I think, I can't remember who said that, you need to be brave and put it out there because it's important. It's important results, regardless of how they end up used. And I think as long as you are convinced that you've done things well and you are open enough to show the way you did things, hopefully those get used in the right way. But at the same time, I think I'm being naive by thinking that that's the only way that things operate in that way. So yeah, I'm still fighting that. I don't really have a full answer to that. I don't know if others here.
I mean, I think, first of all, I think we have to be intellectually honest. That's absolutely, I mean, we have to be intellectually honest. Mm-hmm. I think we also have to look at the preponderance of the evidence. You know, evidence is not a single study. Oh, this cash transfer didn't work here, so forget it. You know, let's look at the whole story. You know, so I think we have to put together the whole story, which means bringing together different kinds of evidence, some quantitative, some qualitative, some descriptive, and telling, you know, an honest, you know, scientific story of our best understanding of what the issues are. And so I think that's the pathway. I also think sometimes one trap I think that we fall in sometimes in public health is thinking that we have to demonstrate, you know, what's fair and what's not fair, you know, what's just and what's not just. That's not a scientific question, you know. And so, you know, there are inequalities that are unjust and we have to do something about it. And we don't have to, there's no p-value for that, you know. So I think we sometimes like demonstrate that racism is bad. Well, racism is bad even if it doesn't affect your blood pressure. It doesn't matter. So I think we also have to be careful that we're not expecting scientific answers to questions that are value questions and questions that we have to grapple with as a society that don't have a scientific answer. So I think we also have to remember that we can advocate for things as citizens, as people, that we think are right, regardless of the science. At least that's you know.
Talking about that, Ana, I think advocacy is very important. Sometimes it contaminates the scientific information, definitely. I had a student, a doctoral student, she was an advocate person, and she was advocate for, you know, some radiation, cell phone, things like that. I said, listen, don't do advocacy, do science. But now, I mean, this was a long time ago, but now I believe that good doses of both of them, it's really, it does a good balance when you want to defend one idea, one problem that happened in urban health. And Gina, just to be very practical, for 10 years, we've been offering one course, one semester by year, that we put together students, post-graduation students, graduation students from different disciplines, public health, geography, and architecture. And this has been very interesting. We have a lot of different professors. We enjoy a lot to teach this course. One semester a year. And it's really rich, the experience. Just like that, you know, sometimes they are, you know, doing some dissertation that doesn't have to do anything with epidata or public or urban health. But it ends up that we decide, I mean, we figure that we are doing the same, you know, in the urban setting, in trying to understand, and health at the end means the most important thing in the discipline. So I think this is a practical thing that I can share.
I think we have time for one more question. Go ahead, John.
Hi, thank you. This just kind of came to me based on the comments you just made. I think, you know, we shouldn't be making kind of decisions off of single data points, but I do think we need to be willing to move our positions based on a preponderance of evidence. And I feel like that seems to be a skill that is getting more and more fleeting in our society. Yes. And both as it pertains to public health, but just in general, this idea of feeling like people have to dig in. And so I'm curious from your perspectives, especially as you're talking about trying to get stakeholders, like how do we try to re-emerge this idea that it's okay to shift a position when the evidence suggests that?
Yeah. It's okay. I mean, yes, you are right, John. We have to do that. And we have to do that visibly, right? I mean, and this is, reality shows us the way to go, right? If we want to change reality, we need to understand it. And that means sometimes we might get it wrong. And we need to be open to changing our minds, I think.
I think there's a lot of sort of what helps me a little bit, cope through this. I'm always thinking about storytelling as a science. And in my mind, it's always thinking we're not at the end of the story here.
Yeah.
I hope, if we were, then, one day we wouldn't need us here. We wouldn't need public health because we have solved the problems, right? And that's the end of the story, but we're not there yet. So it's the story continues, it evolves. There's different stories within stories. And I think that's okay, right? And we're just contributing little pieces here and there to the overall story of humanity and our health and how we're going. And so that kind of helps me a little bit, right? Where and sometimes we make mistakes and sometimes we change our minds, but that's just the story of it, right? And let's document that and tell that story too, right? And then we're, moving on to the next one and to continue that narrative and that dialogue. Most importantly for this, it's when you're feeling, we don't want to be trapped in we made a mistake, we changed our minds, and now everyone's going to be public health suspect and all of that. I think it becomes, that storytelling piece, and also just the relationships that you've built with folks, with the different stakeholders, with the community. No matter what happens, where the funding gets taken away, the resources taken away, there's new rhetoric that's totally the antithesis of everything that we've done. But if you hold fast to sort of those relationships that you have and just spend the time trying to cultivate that, it won't be a big deal if we have to shift and have to say, whoops, we weren't right about this, or we need to try something different. And the relationships should be able to take that if they're strong enough, and we can move on and move forward. So these are the things that I tell myself at 3 a.m. when I try to sleep and, making it through the next day and the next week and everything like that. But I have had this sort of the same worry too. So I just want to affirm you, I see you, and these are things that help me.
Go ahead.
Yeah, I do think it's one of the most fundamental questions that we're facing right now is how do we shift? Yeah, I mean, public opinion about public health. It's a huge question. We had to face it during the COVID pandemic and vaccination. That's where my mind went immediately with your question, and then also with your amazing response. To me, it really does keep coming back to this trust is gained in drops and lost in buckets. And with really strong relationships, they can sustain a lot of conflict, frankly. But I just want to give one super quick practical example of what I would say is a win. We've been managing a very, very challenging Legionella cluster in New York City for the past 6 weeks or so. And, I've had to do many, many, many town halls with community members. And I was just at one on Wednesday night in Central Harlem. And it was Community Board 10, which is one of the strongest and most vocal community boards. That's where this cluster of Legionella cases occurred. And, I went in pretty, worried about what I was going to hear. And certainly they were very critical of our response in the health department. And there were probably about, 60 people or something. And there was 3 of us from the health department leadership team. And my strategy was to really keep the temperature low. Because going in, I knew it was going to be, why has this happened again? Why is this only happening in Black and brown communities? Why haven't you, Michelle Morse, figured out how to prevent this from happening? All of the normal, natural questions a community would have when 114 people got diagnosed with Legionella and 7 people died, and it was a very, very challenging, episode for us to manage. And I felt really proud, not only because no tomatoes got thrown at me, but also by the end of the conversation, I really did emphasize over and over again how the laws that we had on the books in New York City were the first in the country. around registering cooling towers and maintenance of cooling towers, how we were able to do whole genome sequencing to match the strain that got people sick to specific cooling towers, and then really like got into the nerdy details of like every step along the way. How many of our staff were involved, the fact that we're hiring for inspectors to help us with the cooling tower, like, and just really explaining the process and keeping the temperature low while doing it, while also validating, yes, of course, structural racism is a part of the reason why this is happening in Harlem. And by the end, there was one woman who clapped as I described why we were able to close out the investigation. And I was like, wow, okay, one clap and I'm happy. It was like worth it. It was really worth it. But it really, I think it was like keeping the temperature low, not reacting to a lot of very hard-spirited questions, and really trying to validate the concerns that were leading to this, like, I don't believe anything you're telling me kind of situation. So, yeah.
Well, I think on that positive experience, I think we'll end this panel. Thank you so much.